Welcome to the Body Literacy Symposium. This is the Immuno-Menstrual Axis, Emerging Connections in Reproductive Health. So, this is just a normal disclaimer. This is not medical advice or diagnosis or treatment or anything like that. If you need to seek medical attention, do so with your care physicians. All right, so today's session is called the Immuno-Menstrual Axis, Emerging Connections in Reproductive Health. And what I'll be going over with you today is, first off, what is the immuno-menstrual axis? This is a completely new term. The immune-mediated menstrual cycle, so talking about what the immune system is doing during the cycle. Then we'll go into how acute immune events, like getting sick, for instance, like we talked about last session with COVID, how that would affect your menstrual cycle. And then we'll talk about a little bit about chronic immune activation, how chronic immune conditions and chronic inflammatory conditions affect menstrual cycles. And then I will talk about the major reproductive health conditions that we're dealing with today and how they relate to the immune system. And then at the end, I'll talk about the menstrual cycle as an immune health indicator, how we can kind of infer things about the immune system from the health of the menstrual cycle as a vital sign. So just a little bit about me if you don't know me. My name is Nicole. I am a menstrual health educator. I began charting my fertility back in 2015, and I eventually started speaking out about it online, and that eventually grew into Learn Body Literacy, which is a platform I've been using to talk about the menstrual cycle and fertility awareness education. So that's what I've been up to for the past few years. And I'll just start by what is the immuno-menstrual axis. So I'm using this term to describe the communication and interrelationship between the immune system and the menstrual cycle. The ovulatory menstrual cycle is tightly regulated by hormones, and those hormones are in constant cross-communication with the immune system. And they play a key role in both the process of healthy menstruation and healthy pregnancies. The menstrual cycle's immune function operates in a balance, and there's major immune changes that occur at the major points of change of the cycle. Those are ovulation and menstruation. And as I mentioned, the menstrual cycle is affected by acute immune events like getting sick. And we also see that the menstrual cycle's dysregulation is very common when people have chronic immune or inflammatory conditions. So I created this graphic to kind of explain the immuno-menstrual axis visually. And so it really starts in the brain, where it's going to start sending signals to the ovary to begin the menstrual cycle. And that's going to start an interplay of different hormones. The first dominant hormone is really going to be estrogen that's coming from the ovary. And so that estrogen is going to provide some form of immune modulation during the follicular phase, which means that during that time, the immune system will actually cross-regulate parts of the menstrual cycle. And we'll go through this a little bit slower so that you can understand exactly how that happens through each step in the process. So that immune system is activated and giving immune feedback to the reproductive system to actually physically drive the cycle forward, to do different things, like actually help the egg get out of the ovary, for example. So you have this immunofeedback going on during the cycle. And then as you head towards the end of the cycle, it will either result in two things, either menstruation or pregnancy. And we notice that there is an immune response there as well. So the immune system is either facilitating the tissue breakdown, menstruation, or it's facilitating the implantation of the pregnancy. And then after the cycle ends, you menstruate, or if it's a pregnancy, you give birth. You have basically a wound inside. And what happens? The immune system repairs that. It repairs that uterine lining, and it does so at a time where there's very little hormonal support. Menstruation and right after giving birth, your hormones are at a very low state. The hormones are not what's driving this. The immune system is actually driving this repair. So that's pretty much the immunomenstrual axis in 2 minutes. And so we'll go through that a bit slower. So what makes it an axis? An axis is a biological and medical concept, basically. And we've heard of this before with HPA axis, which is the hypothalamic pituitary adrenal axis, or sometimes the HPG or HPO, that means the gonadal or the ovarian axis. Same thing with the brain there. And so the first thing to note is that there's this sequential signaling that's happening in an axis. Information's flowing from one place to the next place to the next place. With that, you also have feedback loops. So like the final component of the axis is actually going to produce something and then send a signal back, and that's going to help regulate the person's homeostasis. And with the menstrual cycle, obviously this is the case. And then lastly, integrated function. This part's definitely true. You can't have a healthy menstrual cycle without this unified complex functioning between the immune system and the hormonal, so it could be seen as the endocrine / menstrual system. So all three of those are all involved in this axis. And here's just a graphic of the HPA axis to give you an idea of how these are usually shown in a circular fashion or something to that effect. You see that the brain is talking to the adrenal gland, and then cortisol is being made, and that's sent back to the brain. Similarly, here we have the hypothalamic pituitary ovarian axis that drives the hormonal menstrual cycle. And as you can see here, there's both negative and positive feedback coming from the brain going down to the ovaries. The ovaries are then making a hormone, which is sending more feedback to the brain, and that's just regulating the cycle as it's going to go forward. So yeah, we typically think of the cycle as hormonally driven. That's like what's drilled into us socially about our cycles, that it's all hormones. But could the immunomenstrual axis reveal that the cycle has an immunologically driven aspect as well? All right, so we'll talk a little bit about the immune-mediated menstrual cycle. So the menstrual cycle has two main immune shifts. When you're looking at this graphic, you can see both immune shifts on either side. And this is a menstrual cycle wheel, which is just meant to show the progression. We typically consider the menstrual phase to be the beginning of the cycle. And the first half of the cycle, called the follicular phase, is generally characterized as having a predominance of type 1 helper T cells and their cytokines, and immunoglobulin A antibodies, which help protect the body from foreign pathogens. During the post-ovulation or luteal phase, you have a different immunity shift. It's characterized as having higher levels of immunoglobulin G antibodies, innate lymphoid cells, and type 2 helper T cells. And the reason for this switch is to promote a different type of immunity that would better support potential conception and implantation. And during this phase of the cycle, also the secretory phase of the endometrium, your uterine lining, you have a large increase in subpopulations of immune cells. So there's a lot of different shifts happening here. And so what I've shown on the graphic is the two major shifts of each half. And that's mainly determined by the hormones estrogen and progesterone. And then I've also listed the specific different types of immunity that we've got during sort of each quarterly phase. So menstrual immunity, how immunity shifts during the fertile window, how it shifts and facilitates ovulation, and then how it facilitates the luteal environment for the uterus. So yeah, estrogen is interacting with the immune cells directly. It's actually the estrogen's attaching to the immune cell's receptors, and it's changing the cell process of that immune cell. And this is important because in a healthy menstrual cycle, we only have estrogen for a short period of time. That's usually mainly during what's considered the fertile window. So this little pizza slice you see here in blue. And this would be when you have higher antibodies and an increased inflammatory response. But we also know that prolonged exposure to estrogen is correlated to higher immune or autoimmune disease risk and cancer risk. So again, the menstrual cycle here is operating in balance. You only have this heightened immunity for a short period of time on purpose. When people tend to have excess estrogen or estrogen metabolism issues, there becomes a higher risk of there being increased inflammatory response. So we want to watch out for that. And then progesterone shifts the immune system and creates a lower inflammatory response that's more supportive of potential conception after ovulation. So there's really a nice balance here with how the body is operating. So to start off in the follicular phase, a protein analysis of cervical fluid, that's the fluid that we make during our fertile window, found that there are at least 48 proteins, and many of those proteins are involved in immune response. And I have listed a bunch of them here. They also found that proteins, certain ones, decrease during the fertile phase. And so it's obvious here that chemical modification of cervical fluid takes place leading up to ovulation by lowering immune defense in order to accept sperm. This is part of how the body is shifting to accept potential sperm during the fertile window. And also note that G mucus is the mucus that holds the highest concentration of immunoglobulins. And we see that most during infertile phases of the cycle. Basically, when conception is not possible is when we have our defenses rightfully all the way up. And I was actually able to see my own G mucus, which is what you're looking at here on the right side of the slide, under the microscope. So all of those little dots that you see there are the G mucus, along with one ferning pattern right in the middle. And this is from my study in 2024, where I looked at the dynamics of cervical fluid across the menstrual cycle. And part of my research about this is what led me to studying the immuno-menstrual axis, because I was curious about the different types of cervical fluid, the different crypts that make them inside of the cervix, and the different roles that they play in not just pregnancy, for example, but also just normal regulation of the menstrual cycle. And so that's what I was looking at by taking my own photos and videos of my cycle each day and looking at the quality and quantity of different types of fluid. All right, so ovulation and the immune system, we're now getting closer to the actual ovulation, what's happening. The immune system regulates and facilitates the complex cellular and molecular events that lead up to and during ovulation, and also following the release of the egg. And ovulation is known as a regulated inflammatory-like process. And the reason why is because it depends on immune cells and immune signaling molecules to remodel ovarian tissue and ensure successful egg release. So the ovarian microenvironment during ovulation is actually regulated by immune signals, and immune interactions extend from local ovarian events where maybe cells are just talking to each other locally to going all the way back to regulating the whole menstrual cycle, or what we would call systemic hormonal regulation via the HPO axis. And also tissue remodeling and corpus luteum dynamics also involve immune processes. So what I'm trying to get at here is that the immuno-menstrual axis reframes this complex crosstalk to describe the broader role of the immune system in reproductive biology beyond just defending against infections. Instead, I'm arguing that the immune system is modulating normal physiological processes that are critical for menstrual health and fertility. So again, yeah, I'm just questioning now, like everything I learned about fertility awareness, right? and the idea that things are, solely hormonally driven. And now I'm learning there's a whole nother layer of things occurring. So next, we'll talk about the actual release of the egg. And luteinizing hormone is typically the hormone that we say it's going to trigger the production of the egg. It's actually going to help the egg get out of the follicle. And it actually signals to the immune system, hey, bring some prostaglandins, some cytokines over here, some chemokines, which are like signalers, bring them right to the site of the basically ready to mature egg. And these immune mediators are going to induce different changes that actually allow that to happen. Vascular changes, there's tissue swelling, immune cell recruitment, similar to when you have some sort of acute inflammation. So they're sending more people to the area. And resident and recruited leukocytes like neutrophils and macrophages in the ovary actually help regulate proteolytic enzymes and extracellular matrix breakdown. So essentially, they break the egg out of the follicle physically. And this is my nice GIF showing you the immune cells doing that. So yeah, those are leukocytes. They're going to contribute to the tissue remodeling after the follicle rupture as well. You have dendritic cells and neutrophils. They're assisting in breaking down the wall to let that egg out, and also angiogenesis. And then macrophages help remove the cellular debris after ovulation and also produce vascular growth factors supporting the corpus luteum that's going to produce the progesterone. There are certain cytokines that are produced from these immune cells, which actually participate in the cumulus expansion, which is a formation of a matrix that helps the egg detach from the follicle. This is actually a crucial step for ovulation. So if this is one potential cause of infertility, if there's issues with these cumulus cells, and it turns out that a lot of this is immune mediated as well. So even at the site of the egg itself, it's kind of like a little jelly that's like surrounding the egg, so that when the egg leaves the follicle, it's protected as it goes on its way to meet with potential sperm. And this is all done by the immune system. So both the egg and the egg getting out of the follicle are both immune events. And I found this pretty cool graphic from a study called New Insight into the Role of Macrophages in Ovarian Function and Ovarian Aging. And these nice researchers put together all these different cytokines, and they're telling you in each phase what exactly those cytokines are doing. So I just thought that was a pretty neat graphic as well. And as I said, yeah, after ovulation, there's an amount of tissue repair that has to happen to the ovary because basically a small wound was created. And so the immune system supports that as well. Okay. Next, we'll talk about menstruation and the immune system. So menstruation is also widely regarded as an inflammatory event. And when ovarian hormones like progesterone fall at the end of the luteal phase, this triggers a cascade of immune-related events in your uterine lining. So the progesterone withdrawal initiates vasoconstriction and cytokine upregulation. And those are the inflammatory signals that precede the tissue breakdown. So your progesterone levels fall, your progesterone talks to your immune system, and then your immune system breaks that tissue down. There are local immune mediators that do this. They're contributing to the inflammation that actually sheds the endometrium. So there are many immune cells involved in this. Neutrophils arrive in high numbers and release proteases and antimicrobial peptides that support the tissue breakdown and protect against infection during the loss of the epithelial barrier. Then you have macrophages and monocytes that are recruited into the shedding endometrial tissue, where they remove cellular debris and orchestrate both inflammation and then we also see uterine natural killer cells, dendritic cells, T cells, Treg cells, and mast cells, and they're present in the endometrium. And this is all contributing to the immunomodulation for inflammatory responses with some form of immune tolerance if the person has a healthy cycle. So you can see that here in the graphic, just that the menses have such a large diversity of these immune cells compared to other phases. Yeah, so I think this is pretty interesting too, that there's both pro and anti-inflammatory or regulatory actions here. Because again, when menstruation is framed as an inflammatory event, it's framed in the way that we think of inflammation equals bad. But I'm trying to say here that maybe there's just like all other parts of the cycle, there's a bit of balance here that we need to really discuss. And maybe that the key to fixing some of our menstrual issues may lie in that balance, right? Trying to figure out what's going on with these pro versus anti-inflammatory regulatory actions. How can we balance that better? So there's also cytokines during menstruation because, again, immune cells make them. So there's pro-inflammatory cytokines that are found in menstrual fluid and found around menstruation. And then there's other immune mediators that attract different leukocytes that will help with degradation, local defense. And then the menstrual blood itself contains immune cells with both inflammatory and anti-inflammatory phenotypes, again, implying there's a tightly regulated response here by the body. It's doing this intelligently. Especially the immune modulators, because they're there to promote tissue repair and regeneration. And we're finding now that maybe researchers are becoming more interested in this. They're like, how are they able to repair themselves so fast? No other area of the body does this. So there's this sudden, interest in menstrual material and what it does and how it breaks down like this. So immune and stromal cell interactions help ensure that the newly regenerating tissue is functional for the subsequent cycle. It gets us ready for the next cycle. And I thought this was a nice graphic from tissue injury and repair in the female human reproductive tract. And they're showing you how these immune cells come in and they're actually repairing your epithelial layer and getting you set for the next cycle. And yeah, I like this one in the middle where it's saying the early repair, there's no steroidal support here from the hormones doing this. That's mainly the job of the immune cells. So immune involvement in menstruation protects against infection, it manages inflammation, it clears debris, and it aids tissue regeneration. These are all essential for healthy menstrual cycles and for the person's future fertility. Now we'll talk a little bit about the uterine immune environment. So during the whole menstrual cycle, what's going on right inside of the uterus during that time? The endometrium contains a diverse array of resident immune cells, and they protect against pathogens, and they also support key reproductive functions. The environment is going to, again, change with the ovarian hormones. It's going to shift during different menstrual cycle or pregnancy states. And I wanted to give a shout out to uterine natural killer cells because they're the most abundant lymphocyte subset in the endometrium during the secretory phase of the cycle and early pregnancy. They comprise 70 to 80% of endometrial leukocytes at that time. And they are phenotypically and functionally distinct from the blood natural killer cells that we have in our venous blood. And they're generally less cytotoxic, so they don't kill cells like in the same way, and they're specialized. They regulate the tissue remodeling, and they contribute to blood vessel formation and also the trophoblast invasion, so basically the implantation of the early pregnancy, and helping remodel the maternal arteries for placental development. So these cells are very important. And we do see issues with infertility related to a lack of them. But there are many different types of cells here. There's macrophages, which is really interesting how their phenotype can change depending on the context. They obviously play a role in the menstrual breakdown and regeneration. You also have T lymphocytes. They are doing a mediation of adaptive immune response and doing mucosal barrier defense. And then Tregs are also especially important for establishing this immune tolerance during the maternal-fetal interface, helping prevent rejection of an early embryo and fetus. And then we've got dendritic cells, which also shape adaptive immune response, and B cells less so. They're in smaller numbers here. Also wanted to note that neutrophils are relatively scarce during the early phases of the cycle, but then we see them before menstruation. They seem to help with tissue breakdown and host defense. And mast cells and other innate cells are also present at low levels and contribute to local immune surveillance. So yeah, there's a lot going on there right inside the uterine immune environment. And then kind of attached to that is the uterine microbiome. So we found that there's a microbial community that exists in the uterus. It's at a lower biomass than what's in the vagina, but it's definitely there. And it has quite a lot of different bacterial taxa. And the microbial components and their metabolites can be recognized by the immune system through these things called pattern recognition receptors. And those exist both on the immune cells and on the uterine cells themselves. And they can detect the microbial signatures from the microbes sending messages. And this modulates your immunity inside. So it's not just our own immunity, but we're working with a microbial community there. And this occurs through innate immune sensing, which is where uterine cells and resident immune cells like macrophages and dendritic cells detect microbes and their molecules and then produce signals. And then we also have adaptive immune engagement, where the activation of antigen-presenting cells by microbial signals can lead to downstream T cell response. And lastly, we also have antibody response from IgA and IgM produced in the reproductive tract, which bind to microbial antigens and influence the community. So again, there's a talking back and forth here between your microbial community and your immune system. And with that, I also wanted to touch on the vaginal microbiome, because the mucosa of the vagina itself is also an active immune tissue. It obviously provides barrier function for us, keeping us safe from pathogens and things, but also signaling function as well. And we see in the epithelial cells lining the vagina that they're secreting mucins and antimicrobial peptides. That's the pathogen defense. And then similarly, you also have pattern recognition receptors, where microbial molecules can trigger more immune cascades. And secretory antibodies like IgA and IgG are also there in the vaginal fluid to bind to microbes and help neutralize them or modulate them depending on what types they are. And so, yeah, these components of innate immunity act together with your microbiota, and that's how you balance your vaginal microbiome and basically your vaginal immunity overall. And that's partially done through the lactobacilli, which dominate the vaginal microbiome. They produce lactic acid, which acidifies the vagina. That helps suppress growth of pathogens. And then there's also commensal bacteria interacting with the host receptors, modulating the cytokines and chemokines back. And there's other things basically besides lactic acid that these bacteria can make, which inhibit certain microbes. Like, all the microbes are fighting, but basically in the vagina, lactobacillus should always win. Okay, moving to the next section here. How do acute immune events affect menstrual cycles? We talked about this in the last session quite a bit. So hopefully you took in some of that good stuff. The hypothalamus, pituitary, and ovarian axis gets suppressed during a sickness event. A lot of times the inflammation or the cytokines created can temporarily suppress the release of the GnRH, which is the hormone that's going to start off the cascade towards ovulation. That's the first thing. You also have the just the stress factor. And I mean a bodily type of stress, not necessarily like like I feel stressed, but that cortisol is higher maybe at that time and can suppress, again, GnRH and the reproductive hormones. And then lastly, high levels of circulating inflammatory mediators during a sickness event can alter the balance of immune cells in your uterine lining. That's why we see so many different changes to people's menstrual blood patterns, like their volume, duration, and pain changes after a sickness event. And I actually looked at this in 2022 when I did my study on COVID-19 vaccines in the menstrual cycle. And we found that, yeah, this was another area where I started to look into the immuno-menstrual axis because people came back with the strangest experiences. And in my practice, I saw people with delayed ovulation, bleeding changes, and anovulatory cycles. Those were the main areas that I saw from vaccines. And then I started looking into the research and I saw, okay, they had looked at the flu and how the flu vaccine had affected, menstrual cycles in the past. And that's really all there was to it until I really learned that, yeah, anytime you disrupt the immune system abruptly, your menstrual cycle will see some sort of effect from that. So it's not even uncommon that we would see that from an intervention like a vaccine. But there was no education around it. So of course, everyone was on high alert, wondering what was happening to them. So yeah, check out both of my studies on learnbodyliteracy.com. They're on there and published if you want to read through the cool literature there. So the next section is how chronic immune activation affects menstrual cycles. First off, high levels of inflammatory markers like the C-reactive protein are linked to longer menstrual cycles and prolonged follicular phases, likely because that inflammation influences pretty much all menstrual processes as we just went through. Then there's the issue of autoimmunity and how autoimmune issues disrupt the HPO axis, and that leads to a whole host of menstrual and ovulatory issues. Also, people who menstruate are much more likely to have autoimmune conditions, so we know there's a link there. Then there's pathogens and long-term immune damage. So conditions that may have originated from a pathogen or an environmental exposure and an illness, especially illnesses that are related to chronic immune activation. Those would be things like ME, CFS, long COVID, long EBV. That's Epstein-Barr, and these things may have long-term reproductive or fertility health effects. That's the long and short of it, that the more pathogen exposures that the person is dealing with, we're going to see more menstrual issues from that. And lastly, I wanted to put in a note about medical misogyny and how it tends to blame menstruation. So immune conditions, they need specific treatment. They cause downstream menstrual effects, but menstruation and hormones are not the core issue. And so unfortunately, with our bodies, our hormones and our menstruation is often just a convenient way to blame the issue on that instead of actually properly investigating the root causes, especially if you know what we know now after looking at these slides about the connection here between the immune system and the menstrual cycle. All right, so our next section is on reproductive health conditions and the immune system. So in my years as a menstrual health educator, I started to see connections between things, right? And this one really got to me because every time that I started to dive in really deep into a different health condition and, what its root causes are, I was finding there was like always an immune or an inflammatory component. And so for PCOS, which 1 in 10 to 1 in 5 people have at this point, it's actually a metabolic endocrine condition with core immune and inflammatory components. People with PCOS show chronic low-grade systemic inflammation, even those with the lean PCOS subtype, and really all subtypes contain some form of inflammation. And elevated inflammatory markers are very common. You also have adipose tissue, fat tissue, inflammation that amplifies immune signaling. So essentially, the fat cells are part of the endocrine system, and they're participating in immune signaling. And we see that a lot with insulin-resistant specific subtype of PCOS. And insulin resistance and inflammation really reinforce one another, which makes this condition really create a very nasty feedback for the person, where it's really hard to kind of get the body into a new state. And yeah, so we see immune-derived inflammatory signals that stimulate excess androgen production in the ovaries, and that contributes to the actual anovulation and the stalling of the regular menstrual cycle from commencing. And we also see other things in correlation with PCOS, like asthma, allergies, thyroid disease. These are all inflammatory conditions or immune-related conditions. Additionally, we see gut microbiome alterations that drive immune activation and metabolic dysfunction. And the immune dysregulation may contribute to PCOS's more long-term risk factors, such as type 2 diabetes and cardiovascular disease. So the main thing that I want you to take away from this is that PCOS actually, one of its core components is inflammatory. That means the immune system is chronically activated. Next is endometriosis, which is an immune dysregulation disorder where the immune system fails to clear endometriotic lesions. And chronic inflammation is a defining feature of this disease. Elevated levels of pro-inflammatory cytokines are found in the lesions themselves, and also in the peritoneal fluid. That's the fluid inside of the abdominal cavity. Macrophages and immune cells are overactive in endo, and they are what promote lesion growth instead of eliminating it. Natural killer cell dysfunction also reduces the body's ability to destroy those lesions. And endometriosis shows many features similar to autoimmune and inflammatory disease. Along with PCOS, it also has related comorbidities that have to do with the immune system. What's interesting about endometriosis is that the lesions actively evade immune surveillance, and they create a little self-sustaining inflammatory environment. And that immune-driven inflammation is a lot of what's contributing to the person's pain and a lot of the other symptoms as well. So yeah, endometriosis, we definitely see this as more of like a systemic immune disorder, because it has to do with why the immune system is not able to clear these lesions, why it's not able to regulate them, and how they're able to bypass the normal immune checks that the body has. Next, we have fibroids. Fibroids also exist in a chronic inflammatory uterine environment. There are increased levels of cytokines in the fibroid tissue. Immune cells are more abundant around the fibroids than in the normal muscle layer of the uterus. These immune cells are actually what promote the fibrosis, like the actual texture of a fibroid is coming from immune cells and their extracellular matrix overproduction, driving the tumor growth. And that also contributes to the collagen and the tissue stiffness. Chronic immune activation may explain progressive growth and recurrence after treatment as well. We see a lot of surgical treatments now, right? Remove fibroids, remove endo, but no real discussion of how the immune system could actually be driving these conditions. And there's so much work that goes into each surgery. To me, it's a shame that we're not doing enough on the front of prevention post-surgery, and what that means. So here we see this as well, that fibroids alter local immune surveillance. That's how the tissue continues to expand. And there's disparities in fibroid prevalence and severity that may involve immune stress responses related to environmental and social factors. So things like racial weathering have been shown to increase fibroids and other menstrual-related conditions as well. So we have to see how the biology and the social are both interacting here as well. Next, we have ovarian cysts. That's, I'm just talking about functional cysts here today. Those are cysts that arise from normal ovulatory processes and involve physiologic inflammatory signaling. And disruption in immune signaling can impair follicle rupture, increasing functional cyst formation. Persistent or dysregulated inflammation may lead to failed ovulation and cyst persistence, and immune hormonal interactions influence cyst growth and recurrence. Chronic pelvic inflammation may increase the risk of complex or recurrent cysts, and cyst-associated inflammation contributes to the pain, rupture risk, and other fertility impacts of ovarian cysts. So this I thought was pretty interesting too. Next, we have thyroid and menstrual issues. So Hashimoto's thyroiditis is an autoimmune disease caused by hypothyroidism, and Graves' disease is the autoimmune disease caused by hyperthyroidism. And in both conditions, the immune system is mistakenly targeting thyroid tissue. And we have autoantibodies that would be driving that inflammation and dysfunction, which can be seen on a blood test on a full thyroid panel. And we found that chronic immune activation leads to thyroid inflammation and disrupts the hormonal pattern because you need thyroid hormone to ovulate. And both hyper and hypothyroidism are associated with different types of irregular menstruations and infertility both. We also have PMS and PMDD. This is also related to the immune system. So immune system involvement is a key factor through mast cells and inflammatory signaling that may contribute to disrupted neurosteroid signaling. And that's where the mood changes and the irritability, the anxiety, or other cognitive symptoms may be coming from. So histamine and different cytokines, they're actually influencing your neurotransmitters, and it's amplifying that emotional and cognitive symptoms that the person's experiencing. And we also see that mast cell activation may explain links with allergies, autoimmune conditions, and other types of inflammatory disorders. And so, yeah, mast cells, they provide this mechanistic link between the bodily issues of menstruation and the neuropsychiatric symptoms that we're seeing in mass, more and more, I would say. And the immune dysregulation also heightens stress reactivity and symptom expression during the luteal phase. So when I work with clients on PMS or PMDD, we're always looking at what's going on through the immune pathway. And similarly, a lot of folks I work with on PMS or PMDD, they have physical menstrual pain as well. So I'm trying to work with them on that, and then we hope to see a subsiding of both types of symptoms. Menstrual pain is immune-driven inflammation. That's what makes the person's pain severe and persistent. And this is true in both primary or secondary dysmenorrhea, like whether or not they have an underlying disease or if they just have regular old menstrual pain. There's a high level of prostaglandins. They're creating stronger and more frequent uterine contractions. There's elevated cytokines increasing inflammation. There's mast cells that can be worsening the symptoms. They're releasing histamine and other inflammatory mediators and things, creating, nerve pain, swelling, heightened pain perception, chronic immune activation, or underlying inflammatory conditions can exacerbate menstrual pain. Oh, I think I see a question. 1 second. Have you come across any information related to ovulatory pain? Yes, actually. I didn't have a chance to put that in here, but basically, when people have ovulatory pain, they're more likely to also have menstrual pain. And that's probably because there's an imbalance of prostaglandins or immune mediators that are driving either the ovulatory pain or the menstrual pain or both. But I did run a small survey on this one time where I asked people that, and I remember everyone basically being like, no, most people had both. It was very interesting. If I come across anything study-wise, I will definitely send it to you, because I've been curious about that as well. Mittelschmers. Oh, see, of course you'd be the exception. That's so funny. Yeah, no, that's fascinating. So the menstrual cycle is an immune health indicator. Basically, we have ovulatory or menstrual regularity as the first indicator. If the person has a regular cycle, then their brain and ovary, that whole axis is probably working well. Their immuno-menstrual axis is probably working well. Irregular cycles are going to indicate some sort of systemic inflammation, chronic immune activation, or maybe autoimmunity. Then we look at menstrual flow characteristics. What does the blood look like? How much of it does the person make? How much stress are they under during their menstrual phases? Like, are they able to rest and bleed or not? These things contribute to, how you can infer about their immune health. Then you have ovulatory or menstrual pain. So if the person has ovulatory pain, if they have menstrual pain, if they have both, this can signal that there is more of a systemic inflammatory status, or maybe other undiagnosed immune-related conditions to look into. Maybe there's a secondary dysmenorrhea going on, undiagnosed endometriosis. That says a lot about the person's immune state. And then there's premenstrual symptoms. So do they have mental, emotional, and physical premenstrual symptoms? How does that correlate with immune neuroendocrine interactions? Some people even get the period flu. That's because of there's something going on with their immune system that has to be investigated, why they're having such a vicious response to a normal physiological process like menstruation that we're supposed to go through monthly for 40 plus years of our lives. And then we're just dropped off and told, oh, well, this is just how it is. And I certainly don't think that's the case. So the Immuno-Menstrual indicator score is just a way of kind of gauging like where you are in the scale. This is very loose, but you can rate yourself 1 to or 0 to 5 in any of these 4 categories and kind of see where you might be in terms of your immune health as well as your menstrual health. So this is really to kind of test the cross section between these 2 bodily systems and how that might be affecting your systemic health. Yes, I just came up with this, the Immuno-Menstrual indicator score. So if other practitioners want to use this as, again, like you were mentioning in your last session about how the intake form should include COVID, some sort of process where you're going through with clients and patients about this cross between the immune system and the menstrual cycle, it can be a helpful diagnostic tool. And I think people just aren't aware that the immune system is involved in menstruation in any way or their fertility or anything like that. So maybe this just creates a little bit more education around that. And lastly, this is a future timeline. So where awareness of the immunomenstrual axis exists and it's a part of standard care. So if that's our future, the first thing is I would like to see more personalized medicine based on menstrual cycles and immune cycles. So let's better study how menstrual cycle phases affect immune responses to surgeries, vaccines, medications, and different therapeutics. And there is some research about this that was in one of my published studies, so I can link you to that if you're curious. Also, developing cycle-informed clinical protocols to minimize side effects and maximize like the efficacy also. Maybe we have higher immune response at a certain time. Maybe we don't get certain therapeutics in our luteal phase because it's not advantageous to us. We have a better response in the follicular phase a week later. So more of this could, if we actually integrated the menstrual cycle into more research, we could do this. That brings me to my second point, which is inclusion of menstrual and immune data in research. So first, ensuring all clinical trials and population studies actually collect menstrual cycle and hormonal data, and with that, immune health data. And then recognizing menstruating bodies as a core variable. Menstruation is not an exclusion criterion. It's not appropriate to exclude us because we have cycles. To improve safety and effectiveness of treatments for all people, it's very important that we actually include us in the research. There's just no way around it. And then public health policy integration. So establishing guidelines for menstrual health as a systemic health indicator in primary care, and then including immune-driven menstrual conditions. That would be anything from endometriosis to PMDD, mast cell issues, long COVID. All of that should be included in reproductive health policy and insurance coverage. I mean, no brainer. And then lastly, educational tools and empowerment. So creating accessible education programs, teaching people to track their menstrual cycles, especially if it interacts with immune-related symptoms. And lastly, empowering patients to advocate for cycle-informed care, fostering agency over treatments, medications, and interventions. That's something I would like to see. So in my research and putting this talk together, there was a lot of nebulous talk in the research, in different articles about, or different studies about the immunomenstrual. So they would call it different things. I saw hormonal immune interplay, I saw immune reproductive crosstalk, and I saw endocrine immune interaction. And what I'm trying to do is kind of bring that together under this umbrella of the immunomenstrual axis so that we can better name what's going on, and really highlight the menstrual interaction with the immune system, and how the immune system is also really the physical driver of all of the changes. The hormones just kind of set the stage, but it's the immune system that's like, they're doing the work in there. So I think that there needs to be a lot more respect and time given to exploring that side of the cycle. So I hope you enjoyed this talk. Thank you so much for your time. Thanks for coming to the symposium. This is a great first day, and I would love to read through the chat first of all, because I haven't had a chance, and also to take your questions. So if anyone wants to take the floor while I catch my breath, please do so.
Just thank you. Thank you for putting a name to this. And I can't help but think about this in the lens, through the lens of the presentation Jamie and I also just gave, and it's so valuable. And I'm probably gonna follow up with you with a few more questions and other things afterwards. So thank you.
Oh, you're very welcome, and thank you so much for your kind words. Yeah, absolutely. The idea here is for us to all, connect and share. And yeah, I just think this is, at least for me, it's becoming such a useful framework to understand a lot of my clients' issues. And I think it's just gonna be like a little light bulbs for a lot of people to be able to understand these connections and how important they are. And of course, how COVID then, becomes compromising to our health on this axis. it's immense. There's a lot of work to be done, but thank you so much. I really appreciate it. Saleh, please.
Hello, and thank you so much for your talk and all the information you provided. I had a quick question to see if you had seen in relation to endometriosis and kind of like the lesions being able to evade immune surveillance, if you have seen anything in the research about like how that is done. Is it like with cytokine related to like cytokine release, or like altered gene expression? And then also wondering too if you have seen anything in relation to like the potential utilization of like CAR T cell therapy in endometriosis, with like that, with the lesions being able to avoid immune surveillance, and also if you've seen anything in the involvement of like the dysregulation of regulatory T cells, and like is there changes in like the tolerance environment and things like that?
Yeah, absolutely. Okay, so basically, there's a couple different ways that endometriosis lesions seem to do this, but one of the major ones is this thing called CD47. It's a surface protein. It's called like the "don't eat me" signal, and it starts emanating from the lesion, and it basically tells the it keeps the lesion protected from the immune cells. So it tells the immune cells not to mess with it. And that's a big part of how the endolesion is able to like not just take root, but then like start up its own hormonal. It starts basically producing its own estrogen, and it sort of becomes like its own tumor driver. And it's able to do that because of this CD47 not basically functioning as a way to evade the immune system. I have a slide on this in my course, Endometriosis Essentials, on CD47 that probably explains it more clearly. But basically, that's what's happening. There's a certain dysregulation of the immune system there, where it's almost like the immune cells can't even see it's there. It's like it has an invisibility cloak on. And that's how it's able to partially evade immune surveillance. And that's also partially how it evades hormonal regulation as well. That's why the endo lesions seem to proliferate despite the changes of the menstrual cycle, or even hormonal suppression being used as a tactic won't always work because of that, because of how it kind of creates its own microenvironment. The second one was a therapy that I don't think I've heard of. Could you repeat it?
CAR T cell or CAR T cell therapy, or like an immunotherapy, kind of utilizing someone's T cells endogenously, presenting them with antigen, and then seeing if that is able to help with like therapy. It's used a lot in like tumor therapy, but was wondering if you've seen anything specifically for endo, since it's kind of like acting as a tumor environment as well.
That's a great point. I know what you're talking about. No, I haven't seen it used for endo, but I would be very curious about how that might affect the environment. And I do think that finding the cure to endo will certainly involve some sort of immune therapy. So I would be very curious to read more about that in the context of endo, and see how that helps. And then I think your last question was in regards to T regulatory cells. Let me see. I'm sorry, did I lose you guys? Am I still here?
You're still here.
Yes.
Oh, okay. All right. Sorry about that. Yeah, so basically that uterine microenvironment is dysregulated, so I wouldn't be surprised if we also see changes there in Treg cells. But I don't have any information off the top of my head. I'd have to look at my resources to talk more about that in detail.
Thank you. This was really helpful.
Thank you so much. I appreciate it. I'm just reading through the chat here. One endo specialist immediately said she would put me on hormone suppressing drugs so endo wouldn't come back after surgery. Yeah, that's pretty common. And that's what I've seen with the endo patients that I've worked with. And yeah, there's just really no discussion of sort of a holistic immune plan for that person. And what can be done specifically by, I like to look at labs, and I like to look at kind of all person's resources that they have available, whether that's menstrual charts or otherwise, and then kind of create a plan based on that, right? But really, the clinical model is just surgical removal. It's really delay and then surgical removal. The delay might include hormonal suppression. And then after surgery, really all that can be recommended is more hormonal suppression. Which may be the right choice from a symptom perspective, but certainly not from, sort of like the radical getting to the root of the issue with this condition. So I'm very interested in how we can sort of adjust that person's immunomenstrual axis in a similar way to how we might adjust someone's hormonal axis if they're suffering from anovulation or infertility or something, and we know that we need to create a better regulation there where all of the organs, the brain and the ovaries are talking to each other. Similarly, I'm curious in how we can modify the immune system to get it to talk more normally to the menstrual cycle and vice versa, and how that's going to affect the person's overall health. Can endometriosis cause autoimmune conditions? Right now, the literature would say that there's correlation between, not necessarily that one can cause, but I remain pretty open-minded when I see different case studies to, if you feel like there's a timeline link there, then I would say it's significant. Even if it's not statistically significant, it's significant to your story. And I would kind of follow that in terms of the treatment protocols that I would want to use, both to address the autoimmunity, why is that happening, and then monitor with the antibody testing to see the person's improvement. And yes, endo, I talk about this in my course, that endo can be considered an autoimmune disease. I go over the similarities and then also the things that make endo unique or different from the typical autoimmunities. But really, I think it can be likened to an autoimmune condition, or it can be likened to a type of cancer, just a really slow growing one. And certainly with CD47, as I was mentioning, we see that in cancer. That's really seen mostly in tumors. So it shares a lot of overlap with cancer, as well as sharing a lot of overlap with autoimmune disease, which to me means that it is like a grave crisis that so many millions of people have it. And yes, I wish you well, Alex, if you're still with us, on your excision surgery. Shoshana also asked, would medication used to treat long-term inflammatory conditions affect your cycle? Yes, and usually like those long medical packets that you're going to get with the medication, they should mention that the person may see menstrual changes. Certainly, I would expect to see some effects, or the person can use their body literacy to investigate if that is a problem for them. Maybe they don't have any side effects. But it's definitely something that if you have body literacy, you'll be much more aware of. So yeah, that is it. You will get access to the recordings. I'm going to upload the presentations to YouTube after this weekend. So thanks again, all of you, for being here and spending time with me, and all of our wonderful presenters today. Again, I'm just so grateful for this opportunity to be able to host the space. And I hope to see you tomorrow. If it's still snowing and everyone's still stuck inside, come hang out. We'll be here discussing a bunch more important topics. So thank you so much.